Hello and welcome to this SLE Euro, the European Lupus Society online meeting. It is an immense pleasure for me to welcome you to this presentation of the Lupus White Book. My name is Laurent Arnaud. I'm the president-elect of SLE Euro. And if you have not subscribed to SLE Euro yet, if you are not a member, please think about this. You have the link here, SLE Euro. And today I am joined by an amazing panel of experts who are going to introduce different chapters that cover many of the unmet needs we have in the context of systemic lupus. So I think you're going to find this event very interesting. We have the opportunity to ask questions at the end. So please use the Q&A function you have on your screen during the talk. And in the end, we will answer these questions with the experts. If you have not downloaded the Lupus White Book yet, well, you can just screen this QR code. It will go for free and immediately in your mobile phone. So this is a good opportunity to have it in the mobile phone and read it in the morning, in the train, or if you're taking the bus, it's a great opportunity. And I suggest we start, and we're going to start by George Bertsias. I will ask all the presenters just to introduce themselves very briefly, to tell us where they work. And George, the floor is yours.
Thank you, Laurent. Thank you very much. I'm George Bertsias, a rheumatologist at the University of Crete. And I will briefly discuss the topic of diagnosis in lupus. So lupus is a heterogeneous disease in terms of the frequency, the sequence of appearance, and the severity of manifestations from different organs and systems. Similarly, the frequency of different immunological features and autoantibodies varies from patient to patient. And altogether, this makes lupus a particularly challenging disease to establish the diagnosis, especially the so-called organ-dominant forms of lupus. So manifestations that are coming from the central nervous system of the kidney are all difficult to diagnose, and diagnostic delays continue to be fairly common even nowadays. Now, in lupus, there are no formal diagnostic criteria. Instead, different classification criteria have been developed originally to be used in the context of clinical studies. But these are also commonly used in daily practice to assist physicians put the diagnosis of lupus. In fact, as you can see, the very recent criteria jointly developed by the EULAR and the ACR in 2019 have a high sensitivity and specificity also for early forms of lupus. Now, for the future, what we hope is that the advances in the understanding of the molecular pathophysiology of the disease, the identification of interferon as a very critical player in lupus may facilitate the development of accurate biomarkers towards the early identification of lupus and the early treatment of the disease. Thank you very much.
Thank you very much, George. This is really amazing. And if you have questions, please use the Q&A function and we can discuss with Professor George Bertsias at the end. So now we're moving on to the second manifestations, which is the skin and the joints. And I'm going to ask Ed Vital to give his presentation. It is actually in an airport, so this was pre-recorded earlier today, but I think it's interesting.
Hello, my name is Ed Vital. I work at the University of Leeds. I'm in an airport, so I'm sorry this is unexpectedly having to be recorded. Musculoskeletal features are one of the most important aspects of lupus. European lupus patients reported that MSK features were the most common symptom and the main symptom they want to go away. But despite that importance, we haven't previously studied this problem enough. Like, for example, how should we assess it in clinical trials and in routine practice? If you look at the top chart, you can see that we looked at patients receiving steroid therapy, and it seemed like many of the patients who were classified as non-responders by the SRI-4 in clinical trials actually do have improvements in their joint counts. Also, who should we treat? Who should go into clinical trials, and who should receive biologic therapies? Many patients with lupus who report joint pain don't have swelling. And you'll hear in detail much more about how imaging can identify inflammation in these patients. But it probably means that we undertreat MSK lupus, and that could be why the current outcomes are rather poor. And at the bottom left, you can see a study that we did in the United Kingdom where we showed that ultrasound-identified inflammation could identify patients whose symptoms would respond best to therapy, provided fibromyalgia was excluded. And when we explored different outcome measures, we could also identify some of them that correspond better to therapy or quality of life than the SRI-4. So we can develop new.
I think we're moving on to the cutaneous manifestations now. I think this was a bit cut.
Which is shown at the bottom left, and is more like a DAS28 for lupus. The other most common feature of SLE is the skin. As you can see at the top left, the inflammation that occurs in the skin is usually the interface between the epidermis and the dermis, and it's triggered by keratinocyte apoptosis induced by UV light. And that leads to rashes. It can be painful, it can have cosmetic impacts, and it can cause permanent hair loss. At the top right, you can see the response in the skin from the pooled belimumab trials, showing the BILAG with significant improvements, but also many non-responders too. Similar to the joints, the BILAG and the SLEDAI may not actually be the most responsive tools, and we're increasingly seeing use of the CLASI, which is a more responsive and continuous severity scale. At the bottom right, you can see the CLASI responses in the pooled TULIP trial results. And what the CLASI does was reveal the more rapid efficacy with separation of the drug and placebo arms at an earlier time point than can be seen usually in lupus trials using BILAG and SLEDAI. In the clinic, many patients' skin fails to respond to B-cell targeted therapies. And here you can see a potential explanation that we found in our lab. We showed that the skin is an important source of type 1 interference, even in the absence of inflammation, as well as other cytokines and chemokines. So there's a non-hematopoietic contribution to inflammation coming from the skin itself that won't respond to immunosuppressants. But in these cases, as you see above, you can see the efficacy of anifrolumab in one of those resistant cases. So this was a patient who had failed rituximab, belimumab, and many other therapies, and you can see then an excellent response to anifrolumab, showing therefore that in the skin disease we may need a different range of therapeutic targets than we do for other manifestations. Thanks very much for your attention.
Thank you very much to Ed Vital. That was really interesting. And now it's my pleasure to welcome Raquel Faria from Porto, who's going to talk about NPSLE.
Hello, good afternoon. I'm Raquel Faria, work in Porto. I am an internal medicine consultant. NPSLE in lupus can be attributable to lupus or not. So every symptom that is neurological or psychiatric or psychological is NPSLE. The question is that no single syndrome has the same dysfunction. And the 19 syndromes that were described by ACR in 1999 helped to define and have more knowledge on NPSLE, but several aspects are still ongoing, and it's really frightening to have NPSLE manifestation. Several serological, cerebrovascular fluid, and imaging biomarkers have been developed and are far more validated now than before, but still with huge unmet needs. Inflammation and thrombosis are the two main pathophysiological ways, and more recently, the blood-brain barrier dysfunction has been one of the mechanisms that have been studied. For attribution to NPSLE, there are several models, but still the gold standard is to discuss in multidisciplinary team, then follow up after treating, and then reassess. And a new study by the university, the group of Leiden, have seen that some of these cases were rediscussed and reclassified as not being attributable or the opposite, to be attributed to lupus. Unfortunately, not every patient has just one syndrome, as if it was not difficult enough, and have three different syndromes, and some are primary, some are secondary, even if attributable to lupus. Minor NPSLE, like mild cognitive dysfunction, mood disorders, and headache, were considered not to be attributable to lupus, at least for immunosuppression or anticoagulation or antiaggregation. But recent knowledge have shown that inflammation probably has also to do with physiopathology. So the major unmet needs that we still have is to have biomarkers that can be used for diagnosis, prognosis, and monitoring for each NPSLE syndrome, since they don't have all the same physiopathology. The ones that are validated are interleucin 6, lupus anticoagulant, and are the only that are clinical used and available. For screening, of course, we don't have how to screen the first stroke, but we really need good screening tools, validated, discriminative for cognitive dysfunction, for example, and for psychiatric dysfunction, depression, and even psychosis. We only see psychosis when they are florid and full-blown, but the first bizarre thoughts, we don't have good screening tools for that. The screening tools for cognitive are only seeing the severe cognitive dysfunction, and for a young woman, this is actually not a good tool at all. Good algorithms to capture each syndrome or constellation of syndromes and have a good practice approach. We need those even, and probably the only way to do it is with huge retrospective for prospective and registries from all the Europe working together, and for each syndrome, just to see if we can figure it out more and help more patients and know how to treat each one of those. Thank you very much.
Thank you very much, Raquel. This was really interesting. And now we are going to move to comorbidities. And I'm going to invite Professor Carlos Vasconcelos, also from Porto, to tell us about infections, vaccination, and lupus. This is a very contemporary theme.
Thank you very much. I'm Carlos Vasconcelos from Porto, and dedicated to the lupus and other autoimmune diseases. I'm not saying my slide. Okay. So, infection is a problem. Patients have a higher risk comparing to populations without lupus, and infection is still a major cause of death and of hospitalization. And we know that lupus can compromise several compartments of the immune system, the innate and adaptive. And the truth is that not one, two, or more cases during the follow-up, we discover that this lupus patient had a primary immunodeficiency subjacent to the autoimmune compromise, because we know that immunodeficiency and autoimmunity are not separated many times. So, by other side, we still have a great difficulty in distinguishing infection from flare, and it's vital to distinguish. So many times we use antibiotics in a flare, thinking in an infection. And by other side, we know that infections are subjacent in the basis of the lupus flares also. So we need to prevent infections, and vaccination is the important way we have to do it. So the main challenges still are trying to individualize the risk in each person, in each patient. Which tests do to see if the patient is in more or risk or comparing to other patients. So we know it when we made retrospective evaluations of our cohorts, but we need to do it prospectively. So there are no standardization of infectious outcomes and treatment regimens, and the steroids are the main example of that. And indeed, there is an underuse of hydroxychloroquine and vaccination, and that is the main challenge. So we need, we need prospective studies about infection risk prospectively and its consequence of infections. And we have to stimulate more research about the factors that can contribute to the infection, including comorbidities, but also the primary immunodeficiencies. And we need biomarkers again. So in order to recognize the patients that have a greater immunocompromise and establish an approach to work up and follow up of these patients. And importantly, we must share information and coordinating efforts between patients, patient associations, and physicians and health systems. Thank you very much.
Thank you very much for the review on the infections. And now we're going to move forward to something a bit different, which is how to measure disease activity in systemic lupus, which is obviously a very central theme. So it's my great pleasure to welcome Professor Luis Ines.
Hello to everyone. This chapter is about the measurement of lupus disease activity. And first, we must recognize that it is crucial to accurately measure lupus disease activity. This has to be made in the daily clinical practice so that we can really apply a treat-to-target approach and to optimize outcomes of lupus patients. Also, to do this, it is essential that we use objective measures of disease activity. These same measures are very important in clinical trials and also in observational studies in SLE. However, up to recently, this was not possible because there are many challenges due to limitations in the classic measures of disease activity. Measures of disease activity such as the SLEDAI and the BILAG and the PGA have many limitations that impairs their actual use to help us in the clinical practice. So there are recent efforts to improve this, to improve the classic measures, but also to develop new improved measures such as the SLE disease activity score. This one is the first with both high accuracy and sensitivity to change, and that is also practical to use in the individual patients, so that it is able to assist us in the management decisions in the practice to make our clinical work easier and to achieve better outcomes. This is the summary of what will be discussed in this chapter. So I hope that you enjoy this and also the whole book that we are offering to you. Thank you so much.
Thank you very much. So for more details, you can absolutely have a look at the Lupus Workbook and you'll have details about the SLEDAS. And now that we've learned how to measure disease activity, it's going to be really interesting to see if we have targets that needs to be reached. I think everybody has heard of low disease activity remission. And so I'll have the pleasure to welcome Professor Andrea Doria to enlighten us about this.
Hello to everybody. I'm Andrea Doria. I am professor of rheumatology and head of rheumatology unit at Padova University. The treat-to-target has been proposed in SLE, and the two targets which should be achieved in the management of the disease are remission and low disease activity. The problem is how to define these two targets. And on the top left corner of the slide, you can see the two concentric definition recently proposed and very well accepted by the international community. The most stringent is the Doris definition of remission, and the less stringent is the lupus low disease activity state, also called LLDAS. Doris definition of remission is based on clinical SLEDAI 2K equal to 0, PGA lower than or equal to 0.5, the prednisone daily dosage lower than or equal to 5 milligram per day, and the background stable treatment is allowed. The LLDAS is based on SLEDAI 2K lower than or equal to 2 or equal to 4, PGA lower than or equal to 1, a prednisone daily dosage lower than or equal to 7.5 milligram, and again, the stable background treatment is allowed. And there are no questions that the achievement of LLDAS and Doris definition is associated with a better disease outcome. However, as you can see on the top right corner, many other definitions of remission and low disease activity have been recently proposed, and they differ from each other in many aspects, including their stringency. In other words, the probability of being achieved. And I think that it is important in clinical practice as well as in observational study to have different definition of remission and low disease activity, since we can use the most appropriate for the population that we are going to study. Very little is known about the management of SLE patients during remission or low disease activity. What we can say that in patients, especially in patients with a stable remission, an attempt to minimize and also to stop the glucocorticoids first, and maybe later on even immune suppressant should be considered. Thank you for your attention.
Thank you very much. Now, one way to achieve remission is to use corticosteroids. We know it's a tricky subject because we need to use them, but not too much, not for too long. So, Andrea, again, can you tell us more about the use of corticosteroids in SLE?
Well, I am the same Andrea Doria than before. So, if you go on with the slide, thank you. Well, again, glucocorticoids remain a mainstay in the treatment of SLE due to many reasons. Due to their rapid anti-inflammatory effect and their slower immune suppressive effect, which is due to their effect on all the cells of the immune system, as you can see on your top left. But not only, also due to their efficacy in controlling disease activity, even the most severe manifestations. Unfortunately, their chronic use can lead to a very well-known short and long-term side effects, can lead to damage lateral, and also many others adverse disease outcomes. There is a great debate among the experts whether or not a daily dosage of prednisone, which can be considered safe, does exist. Some expert thinks that a dosage lower than or equal to 5 milligram per day can be considered safe. Some other a dosage lower than or equal to 7.5 milligram per day can be considered safe. I personally think that the only daily dosage of prednisone which can be considered safe is 0 milligram. And what is the reason? If you look at the table reported here, where we analyze the increase in damage index according to the level of remission achieved by our patients, where the level of remission, where clinical remission on a low prednisone daily dosage, a dosage lower than or equal to 5 milligrams per day, or clinical remission of glucocorticoids, or complete remission, again, of course, of glucocorticoids, you can see that we did not find any difference, any significant difference among the different level of remission in patients who achieve 1, 2, 3, and 4 consecutive year remission. By contrast, we found a significant difference in patients who achieve 5 and more year remission. That is, the patients who were on a low prednisone daily dosage accumulated significantly more damage than those who were glucocorticoids free. This means that in the short term, to achieve a clinical remission is more important than a low prednisone daily dosage intake. But in the long term, even a low prednisone daily dosage intake can contribute to the damage progression. That is the reason for which it is ideal to be able to stop glucocorticoids. Thank you for your attention.
Thank you very much. So we know that among the side effects of chronic corticosteroids use are cardiovascular disease in systemic lupus, and this is also partly due to systemic lupus. So it's a pleasure to welcome Professor Tektonidou to give us more detail about this potentially severe complication of SLE.
Very much. We know that cardiovascular disease is a major cause of morbidity and death among SLE patients, and especially among women and patients at younger age compared to the general population. Recent systematic literature reviews and meta-analysis have shown a 2 to 3-fold higher risk of stroke and myocardial infarction in SLE patients versus the general population, and a 2 to 3 higher risk of subclinical atherosclerosis in patients with SLE compared to healthy controls, but also compared to rheumatoid arthritis patients and patients with diabetes mellitus, both disorders of high cardiovascular risk. Regarding its pathogenesis, an interplay takes place between the traditional risk factors, such as the demographic factors, age, gender, and also the classic traditional risk factors such as the obesity, hypertension, diabetes mellitus, smoking, and SLE-specific risk factors, including disease duration, disease activity, disease damage, specific clinical manifestations such as renal involvement, and especially hypertension, proteinuria, and renal insufficiency in the context of lupus nephritis, lupus-related medications, including the deleterious effect of glucocorticoids, and genetic risk factors. The recent EU recommendations for cardiovascular risk management in RMDs, rheumatic diseases, including SLE and the dysphospholipid syndrome, suggested a regular assessment and strict control of disease-related and traditional risk factors, including cessation of smoking, management of blood pressure, of lipids and diabetes, a target for blood pressure of less than 130 and 80 that was introduced for the first time, the use of ACE inhibitors or ARBs, especially for patients with lupus proteinuria or in all patients with SLE and hypertension, the attainment and maintenance of low disease activity, the use of hydroxychloroquine in all SLE patients, but also for its additional role in cardiovascular risk reduction. Aspirin is protective, atheroprotective, especially in patients with high risk antiphospholipid antibody profile. Glucocorticoids are atherogenic. The lowest possible use of glucocorticoids is recommended, and their discontinuation as soon as possible. Also, patient education about the risk of the cardiovascular risk and counseling, including lifestyle modifications such as diet and exercise, are also recommended. Thank you very much.
Thank you very much. I'm sure we're going to have lots of questions because this is quite an amazing theme. So please don't forget to use the Q&A question at the bottom or at the top of your screen to ask the questions, and we will share with the full panel of experts right after the talks. So moving on to a very important theme. We know that lupus is mostly a disease of young women. So I have the pleasure to welcome Professor Tinkani to talk about pregnancy in systemic lupus.
Thank you, Laurent. Thank you for inviting me here, and thank you for including this topic in the white book. I am a rheumatologist. I work in northern Italy, and it's a long time that I am looking after this topic in lupus because it's important. It's important, you told already, because many of lupus patients are women, and many of these women are young women, so they need to be accompanied through their life, and their life often include the wish of a family. So to do this, we have to consider three different areas. The area of counseling pre-pregnancy. So this has to be done according to the international guidelines as soon as possible when you make the diagnosis of lupus, because a patient should be aware that she can be a mother, but there are some caution to be taken, like disease activity that has not to be high in that period. It's important to look to autoantibodies, because some autoantibodies per se are able to give some unwanted effect during pregnancy. Also, we need to speak to our patient about contraception, because for personal reason or for reason linked to the treatment, that they may wish to postpone their pregnancy. And finally, we also have to share with our patient information about the drugs that can be taken during pregnancy and lactation, and drugs that cannot be taken during pregnancy and lactation. And therefore, in this case, they need, in fact, contraception, as I said before. The second area is the area of pregnancy monitoring. When the pregnancy is started, we have not to leave our patient alone. On the other way around, we have to look at our patient together with our colleagues from obstetric department, and to be a team, a sort of multidisciplinary team to look after the pregnancy, because the obstetric have to do their job, looking at the fetal growth and whatever else with their competence and machines and everything else. And we have to look at the disease of our patient and to keep it in remission, because we know that an active disease is not compatible or it's rather dangerous for the good outcome of the pregnancy. And finally, we have to look also after what happened after the baby is born, because puerperium is often a difficult period for our patient. And the reasons are of two kinds. There are two kinds of different reasons. The first one is that puerperium is a period in which sometimes lupus can flare. And when the disease flares, the patient needs treatment, and the treatment has to be balanced with lactation and so forth. So it can cause some conflict also in the mind of the patient. The second reason is that the month or the few months after delivery are very hard for even a normal human. So they are hard also for our patient that are usually suffering of fatigue, joint pain, and something else. So this period has in some way to be protected, because otherwise the patient can be suffering also from depression and other psychological problems, comparing themselves to the other mothers that in their view looks more fit, even if usually is not that true. So I am particularly great that Laurent wanted to include this chapter in the White Book, because I think it could be of help for healthcare professionals and also for patients. Thank you very much.
Thank you very much. I think our idea at SLE Euro was very much to make a list of unmet needs. So I'm very happy that we were able all together to include this chapter in the Lupus White Book. I think this is really, really great. Another question which is very important is lupus one disease, or is this several diseases? And I'm very happy to welcome one of the most expert people on the question, which is Marta Alarcón, who's going to tell us about the stratification of SLE. Marta, the floor is yours.
Thank you very much, Laurent, and thank you very much for inviting me to this webinar. So one of the things that we know about lupus is that it is a very heterogeneous disease. And so one of the questions that we have is that in the bottom of all those clinical characteristics that have some of the patients, whether there are molecular differences that can also be filled with certain molecular characteristics to let us know more or less how the molecular pathways could be involved in the disease. So what you have is some of the studies that we recently did, and that has been published last year, which was about the stratification of lupus using these molecular signatures or markers in a more general way, without actually just looking at one thing or another, but really globally, as the extent that the genome and the transcriptome allow us to do. So what we found in the first figure, which is the mosaic plot, we also took several systemic autoimmune diseases and put them together. And what we found were a number of groups. One was inflammatory, the first row, which includes in red lupus patients, but other patients with scleroderma or rheumatoid arthritis. A group that was undefined, which was a group of low activity in the case of lupus patients, a lymphoid group, and an interferon group. When looking into how these groups were related with clinical manifestations, we did find several different enrichments of those clinical manifestations, autoantibodies, but also even genetic differences. Now, these patients happen to be, as I told you before, when we looked then in an inception cohort, patients, for instance, that could have a sort of relapse or remission type of behavior, but also patients that remain stable. Most of the patients that remained stable in the blue 35% were patients that were of this undefined low activity group. While the patients on the relapse remission, what happened is that if they were interferon at the start, would go into the low activity group and then go back, for instance, to the interferon group, to the same group they originally were at. And this is during a 14-month period. So this is something that's important because it tells us that at least for this 14 months, most of the patients remain in the same molecular pathway, even if they go into disease activity, and at least during that time, they actually do not change. So from the point of view of the clinical importance of these type of groups, we actually wanted to see whether if we actually took the groups, how they would respond to different treatments. And this is very important. There are some targets for treatment, like, for instance, belimumab, which is the figure on below, that we actually saw that, for instance, if you take the diagnosis and simulate or try to predict how many patients or what percentage of patients might respond to belimumab, only around 60% could be predicted to respond. But if we put them in the in the different molecular groups, what we found is that this prediction increased to 85%, more or less, particularly for the interferon group. So this type of molecular work can actually help us to really look into the lupus patients. And we have actually also detailed, for instance, ways of analyzing individually the molecular pattern of a patient with a type of a website actually that's called MyProSLE, where transcriptome data can be included and the prediction of how the patients might actually respond or flare or enter into long-term remission is possible. So I believe that within the molecular patterns of disease, we are able to stratify the patients, predict their clinical response to treatment, and predict as well whether they might respond, whether they might flare or enter into a long-term remission. And this is something that it's a promise that we would really like to test further into with real data and real patients that we can directly test. Thank you very much.
Thank you very much. So again, if you have questions, and I'm sure we're going to have lots of questions, please use the Q&A function. And we have an amazing panel of experts today. Everybody's highly specialized in systemic lupus, so this is an amazing opportunity to discuss. And well, this is now my turn just to talk about a controversial theme, which is digital health and systemic lupus. I just want to say that big data are everywhere around us. I think everybody has heard about big data. It's basically collecting a huge amount of data, which is generated because we use our phone, we use our mobiles. We also use the healthcare system. And these data may be analyzed to give us a completely new perspective on different questions that we assessed before using other techniques. And the main difference is that using artificial intelligence, using machine learning, or even text mining to have a look at electronic health records, we can extract lots of information that are going to bring us some very, very interesting findings. What it enables us is to collect real-world data. And we must say that when we performed a randomized controlled trials, the patients who agreed to participate are highly selected. They may not reflect the general population of patients that we take care of. So by collecting and analyzing this data, we may generate some real world evidence that we can use for several things. We can perform some pharmacovigilance analysis to check side effects of treatments. We can also understand epidemiology of systemic lupus, how many patients with lupus there are in different countries in Europe, in the world, what's the incidence, what's the prevalence. We can go toward precision medicine. This is just what has been discussed by Marta Alarcón, finding biomarkers to predict the course of our patient. This is something really important for prognosis modeling. A true question I think we're going to discuss is there a way to know whether someone with systemic lupus will have a nice trajectory or unfortunately will have a bad trajectory? And we are currently really lacking good tools for that. So the idea would be to incorporate bit by bit, with the help of the patients, with feedback from doctors, because I think both are really needed, feedback from patients, feedback from doctors, a bit of digital world in the way we manage the patients. I think with the COVID pandemics, we have included a lot of telemedicine, but we know that this is difficult because finding swollen joints, counting joints online is really difficult. On a cam, on a photograph, on a phone is impossible. So there are other ways that we can use to collect interesting data that may help us to take care of our patients in a better way. Something we often discuss is that we are not seeing our patients very often, at maximum every 3 months. But there is a life between these times. And so it's really a good opportunity to collect data on a daily basis to know better how our patients are doing. Then there's the question of the time. How can we incorporate these data in a normal consultation? So I think digital medicine can really revolutionize the way we perform medicine. We can use computer-assisted diagnosis in some remote area where expertise is lacking. We can use chatbots to answer questions from the patients. We can use artificial intelligence to check that there is no problem with the treatment we give and that therapeutic adherence is optimal using smart reminders. We can even perform digital clinical trials. So I really think this is the future. But we know that the future is a bit complicated and we have to start slowly, bit by bit, with a lot of feedback from doctors, but also from patients. So I thank you very much. In case you have not downloaded the Lupus White Book yet, and you have been more than 1,800 to download, well, you can screen this QR code. It will go immediately in your telephone. I just wanted to remind you that now, is a great panel of experts which is available to answer your questions. So please feel free to ask any question you wish using the Q&A function of your screen. And well, we're going to answer these questions. So just give you a few seconds to ask your questions. Thank you very much. I think all my colleagues will come online again all together and we can discuss. So maybe the first questions are coming. I can see them. I'd like to start by a question maybe to all my colleagues, which is the prediction of the patient course, the patient trajectory. What would you recommend as a way when we are seeing a new lupus patient to decide whether the course of this patient is going to be more favorable or more unfavorable? Do you think the answer is in the genes? Is it genomics? Is this biomarkers? Is the other techniques? What do you think?
A combination.
Yes. Who do you want to start with? Yes. I would say we still have to develop the methods to be able to predict flares, but a combination would be the best thing, of course, because when it comes to tissues, we don't know how they will develop yet. So we can look at it in blood, but we cannot really look at it deeper, so to say. So I agree, combination.
But for now, in clinical practice, is close follow-up, complement, and the double-strand DNA. That's real life.
Also to have a high number and amount of different autoantibodies.
And the data that is useful, it's always changing from the first visits and during follow-up as we get to know better the individual trajectory of each patient. We can make more accurate predictions of how the patient will have its evolution. For now, the expectancy for the genetic markers and biomarkers is a hope, but it's not still the present day. But there are clinical markers, analytical markers, autoantibodies, the actual organ involvement types, the need for immunosuppressants to control the disease. All these are useful data for predicting how the patient will go.
And if I can add something, I agree with Luis that make a very good synthesis. Mm-hmm. But there is one thing more. You can predict that a patient will have a good outcome if you can build a good relationship with this patient. Because if you cannot do it, you can predict whatever you want, you can have the best treatment, but he will not take the treatment. So is very important also to have a good relationship with patients.
Thank you. I think this is really great feedback. We have another question from one participant. Lots of questions about cardiovascular risk are related to arterial manifestations. But here we have a question about venous involvement. Is anyone willing to comment about the risk of venous thrombosis, either related to COVID, non-COVID, antiphospholipid antibodies, or generally speaking in the context of SLE?
Start. So when we discuss cardiovascular disease risk, we mean mainly arterial events and arterial endothelial dysfunction in the arterial level. Venous thrombosis also happens in the context of SLE and especially in the context of antiphospholipid antibody positivity. But there we need to think that not every patient who has positive antiphospholipid antibodies is at high risk of venous thrombosis, but there are some specific characteristics, the so-called high-risk APL profile, which means that the existence of persistently positive antiphospholipid antibodies, mostly at medium to high titers, or the presence at least of one of them that are mostly associated with a higher risk of thrombosis, such as the lupus anticoagulant test, or the presence of double or triple positivity. These are the classic risk factors that are associated with higher risk of venous thrombosis. But also we need to think about and never forget about the classic risk factors for venous thrombosis that for the general population, which means perioperative period, especially the post-operative period, the period of pregnancy, and all the other classic venous thrombosis risk factors.
Thank you very much. I think another very interesting question relates to the measurement of disease activity and our targets, such as remission and low disease activity in a perspective of treat to target. Do you think that these targets are achievable? Do you think we can reach remission in systemic lupus?
Is for me? Yes, absolutely. Yes, I think that the clinical remission is quite common in clinical practice. Of course, it depends from many factors, and among others, most important are the factors related to the population. In other words, the ethnicity, but not only ethnicity, also, for example, the type of health care system, the type of insurance. There is a great variability among the different countries. And so this is a very important factor. For example, in clinical practice, in our cohort, which is a Caucasian cohort, the white cohort, the clinical remission can be achieved up to 70 to 80% of patients at 1 year. It is clear that then, since SLE is a relapsing remitting disease, of course, if you look at 2, 3, and 4 years, these percentages tend to decrease. But in any case, in the short term, is not uncommon to achieve this target. And also in the Johns Hopkins University, in the paper from Michel Petri, their patients spent at least 40% of the follow-up, which is a long follow-up, in clinical remission. So I can say that the clinical remission is not rare in SLE patients.
Thank you. I suggest we hear another perspective, is that of Luis Ines.
Yes, thank you. I completely agree with this view that at least in Western Europe, the reality that we know better, it is possible for the large majority of our patients to reach the treat to target that we wish. So the main challenge now is to maintain over time this target stable over time. And this is an important and a big change for the management of our patients from a situation where it was difficult to reach the targets. Now it is not only feasible but common, and it's the most common reality. And now we follow to the next target, that is to maintain stable this over time. And I agree that building a partnership with the patient is very, very important so that we can work together and achieve the best outcomes.
Oh, thank you, Luis. It brings us another question, which I think is really interesting, is pregnancy. We know that when lupus has been active during the previous months, there's a risk of flare, a risk of maternal complication, fetal complication. How are you able to recommend a precise target to start the pregnancy? Would you recommend a low disease activity? Would you recommend remission strictly to start a pregnancy in good conditions? What is your opinion? I think it's still a bit of a matter of debate.
So, the disease should be the disease activity should be as low as possible. However, you have to balance the wish of the patient with the wish of the doctor. But this is not too difficult, because I tell you something that is difficult, that a lady who is very unwell won't have a child. So certain well-being should be there if the patient want to plan a pregnancy. However, sometimes we have unplanned pregnancy that comes when the disease is active, and we will try to manage. And in most of the cases, we can also manage nowadays with these events. However, of course, this is more risky situation.
I fully agree with this. We hope for remission, but we all know from real life that this is not always the case.
Yes.
Maybe another interesting question is about cardiovascular risk, because we know this is a major complication for our patients. So I'm just curious to know, what kind of screening do you perform? What kind of screening do you recommend in the EULAR perspective?
I assume that I'm the person that should respond. Okay. According to the EULAR recommendations, we need a regular assessment of classic cardiovascular risk factors, including blood pressure, lipid levels, smoking, diabetes, glucose levels, starting within 6 months after the first visit or the diagnosis, and then at least every 12 months. But besides the traditional risk factors, we need to also assess the modifying disease-related risk factors, which is again disease activity. So attainment and maintenance of disease activity, avoidance of disease damage, and all of them in association with less toxicity, considering the medications that are associated again with high risk, with high cardiovascular risk, which is again the glucocorticoids. Other ways of assessing cardiovascular risk are the so-called generic cardiovascular risk prediction scores, such as the Framingham score that everybody knows, and the European Heart score. But evidence has shown that both of them underestimate cardiovascular risk in patients with SLE, and actually in almost all patients with rheumatic diseases, systemic rheumatic diseases. So this was the reason that the modified scores were introduced, such as the modified Framingham and the modified Heart score, multiplied by 2 and 1.5 respectively, that were it has been shown that perform better in the prediction of cardiovascular events, because the target is to predict the events. But again, not even the modified or the SLE adapted scores, as we call them, are good for the prediction of events. So we need to have SLE specific prediction scores.
Okay, well, this is really amazing. And I think it brings us to another question. This is the end almost of this session. So I'm going to go to the start, which is the diagnosis of systemic lupus. We all know that some patients may see several doctors before the diagnosis of systemic lupus is made, because a diagnosis of early systemic lupus can be difficult. So this is a question to everybody, to Judge Bertsias, to the others. What would you recommend to decrease the diagnosis delay for systemic lupus? Do you believe in new techniques, computerized assessment? Do you think we need to build networks such as Reconnect, for instance? Do you think SLE Euro may play a role? What's your perspective to reduce the diagnosis delay? George, do you want to start?
Well, indeed, awareness over the disease has significantly increased during the last years, and that has helped to reduce a bit the diagnostic delay. I think that the message should be that whenever we face a patient who has at least two organs that are affected, or there is a combination of immunological abnormalities and another clinical manifestation, a general practitioner or an internist should consider in the differential diagnosis lupus. So I think, yes, in the future, we might be also assisted by the presence of a biomarker like interferon signature, which I think will act as an extra item in the let's say, if you think of the classification criteria, it will be the fourth maybe criterion to be considered to facilitate diagnosis.
Oh, this is nice. Would anyone else comment on early diagnosis? Carlos Vasconcelos?
Well, I think that public information is the key for success, because biomarkers we have a hope. But so the concept of undifferentiated autoimmune disease is very important, and it is understandable by the population, because population talk about autoimmune diseases. So this is the time of comprehensive and information, and it's our responsibility to do it.
Thank you very much. We have some feedback from Marta Alacon.
Yes, I agree with Carlos. This is a very important issue, and I don't think that reaching the criteria should be the goal. There are many women who have few symptoms and who no one knows what they have, but they have something. So I believe it is very important to consider this, to follow them. They might never reach the criteria, and they still might need some type of treatment. And this is why I believe the combination of the molecular signatures should be even included as soon as possible, in order to know which would be the best treatment, and not just steroids, because that's what's allowed. So there has to be a change in how we actually consider what a diagnosis of something is. And that's not something that it's called that or that or that just because of a clinical criteria, but that to recognize that those persons, those women, have indeed something that is bothering them and keeping them from being productive and normal well-being citizens. Thank you.
Thank you very much. I think patients at the center of the care is really the best way to conclude this session about the Lupus White Book. I would like to say thank you very much to all the co-authors and speakers that have been here today. We are an amazing panel of lupus experts, and it is not so common to be reunited all together for a session across Europe. So this is really, really great. If you have not downloaded the Lupus White Book yet, well, please feel free to do that on our website. If you are not a member of SLE Euro, you have to be a member. This is really, really important. And I just wanted to say, well, thank you very much, and have a good day to you all. Thank you for coming, and thank you for listening to this session about the Lupus White Book. Thank you. Bye-bye.
Thank you.